Dear friends, I am back now, and my next talk is about the arthroscopic transosseous rotator cuff repair. So let's start with some consideration that there is a long history of rotator cuff repair with open technique, starting in the early 19 till now, and you see that many techniques have been described in this time. Then, a few decades ago, arthroscopy came over and introduced the techniques. You see some old pictures of my early procedure with the side-to-side, different tools, the Caspari punch to pass the sutures, and we were trying to mimic rotator cuff repair by the scope, reproducing what is happening in open surgery. And in fact, what is the gold standard for comparison of all repair techniques in peer-reviewed literature? Open rotator cuff repair is still the gold standard, even in the recent literature, to be considered as the standard, the reference, the benchmark for any kind of repair we do in our rotator cuffs. So, since I am a senior surgeon, I start to understand that there is a circle in the history and the technique. We started with the open transosseous, at least the senior ones. Then we moved into the mini open transosseous with a little tiny cut in the deltoid. Then mini open using the anchors that were created for arthroscopy. So using these little anchors, we did the mini open and we repaired the cuff. Finally, we achieved the arthroscopic repair with anchors, and then different techniques were evolving. Single row, double row, transosseous equivalent became very popular. And now probably this pendulum is swinging. And this is an image that I published in literature something like almost now 10 years ago. And it is very similar what was published by my friend Pietro Randelli about the evolution of the surgical treatment of rotator cuff. You see that we had the open repair, the mini open, arthroscopic cuff repair, and now arthroscopic transosseous. Again, the pendulum is swinging back and forward. Is this a very new procedure? No, not really, because there are many attempts in the last 20 years or so to reproduce by the scope the arthroscopic repair. Dr. Flieger from Germany, the giant needle, Sumant Kristen, my good friend with the arthro tunneler, who was inspiring me so much. He came to visit me and he was teaching me about this early in 2000. And then an ACL guide was used. Beauchamp from Canada is this curved passers. Herbert Resch described this curved hollow needle. It's very similar somehow to the giant needle. Myself with the tailor stitch, and recently Kuroda with a customized drill guide. So there are many people thinking about how to do an arthroscopic transosseous repair of the rotator cuff. Now, I will want to report to you our experience. This is about the clinical results, the first paper, 2012, and with this arthroscopic transosseous anchorless rotator cuff repair. As preliminary reports, we had a very good healing at MRI using this technique and the X-box configuration as described by Sumant Krishnan. And it is a very good one, and it is really satisfying us, although it was a low number and just a rather short follow-up. Then I kept under observation my experience sharing with my friends here, and we achieve a higher number, one or more than 100, a minimum 1 year follow-up with satisfactory subjective clinical outcome and no complication. This is also important. So now we start having more cases, a more significant follow-up. But this is the most interesting and important paper of our research. We try to understand if there is a difference in the clinical outcome with a single row and transosseous, and we did a retrospective comparative study with a level 2 of evidence with an MRI evaluation at a minimum 24 months of observation. So quite significant in terms of design of the study. What came out here is interesting. Listen to these numbers. We compared the arthroscopic transosseous and the suture anchors that were vented in a single row. 50 case versus 42, so similar group. Retear, we had 18%, 19%, similar, the same. And according to the Sugaya classification, the retear, grade 1, 38% in the transosseous and 23% in the vented anchors. Grade 2, 40, 31. But what was interesting, so similar numbers. I mean, the clinical and the MRI results are very similar. But what was interesting to me is this, that the grade 3 was 4% in the series of the arthroscopic repair compared with the 26 in the suture anchors and transosseous. Overall, we had 82%, 80%, so overall the results are very similar. But grade 3 is important to my mind. Why? Because there were no differences. The UCLA constant and as a score, the healing was good, 82 versus 80%, no significant. But 26% is type 3 of Sugaya classification, and it is defined that like a healing or rupture in continuity. That means that the tissue that you are seeing in the MRI is not a good strong tissue, is something that you see, but it is not really mechanically working. So probably with the arthroscopic transosseous, you may achieve a better biological response. Now let's move to another important point. To my perspective, I work in a country where expenses are important and they will become more and more relevant. And look at this study coming from the United States comparing the cost per case, the first column, transosseous equivalent, and the gap between transosseous and transosseous equivalent. You see that with a small tear, you may save about, in the United States, almost $1,000. If you have a medium tear, this money saving is reaching $1,100 and more. With a large tear, it is $1,200. With a massive tear, it is always around $1,000. And overall, comparing the different sizes of the tear, you can save an average of $1,100 in a total cost, especially expressed by the implant cost that is $800 in an average setting. So you can save money, but what is important, once you become a good surgeon, also the case length is not longer than this. So arthroscopic transosseous is cost effective. That is important. And it is confirmed here by these graphs that you can see very clearly. And you see that arthroscopic transosseous equivalent is transosseous equivalent. The blue one is transosseous and the other one is arthroscopic. And you see that the cost is clearly higher in the transosseous equivalent using anchors. And again, here you see the comparison of the clinical outcome, and you can tell that they are very similar, but still transosseous is doing a little better in the long term. So you see the green bar is higher for the transosseous. Furthermore, it is a very creative technique. You can have different possible options. This is what it was described by my friend and co-worker Claudio Chilemi, who described this figure of 8 for the repair, and using this little peak button that is used when the bone is not that good and you want to be sure that your hold in the bone is solid. But many other techniques were described by Steve Snyder, the cable technique, the total knotless, and the subscap, and so on and so on. So I think that the fantasy of the surgeon is the only limit. So as a conclusion, this repair is equivalent to current arthroscopic methods for integrity and biomechanical strength. It is reliable, reproducible. You can use multiple suture. You can augment your bone tunnel in order to prevent any cutting through the bone. The anatomic repair can be done avoiding overtensioning, and it is an easy reoperation in case of retear or in case of revision. So I think that it is a good option in our hands, and these are the options for our shoulder meeting in the next year, hoping to meet all of you in person. Thank you very much.